All right, hi. So now we're going to start talking about Chapter 7 in EHDC, diseases and conditions of the musculoskeletal system. So, purpose of the musculoskeletal system, remember, it is framework, it is movement, all right? It is muscle, and it is bone. It's also going to include other pieces of connective tissue, ligaments, tendons, the cartilage, joints, etc. The idea is that joints allow for a articulation between two bones, and muscle allows those articulations to move. So remember from A and B, quick overview of the muscular system, some of the main muscles of the body. Remember, we have three primary types of muscle. These are skeletal, smooth, and cardiac muscle. They all look a little different under a microscope exam. So there's non-striated and striated muscles. Striated are skeletal and cardiac, whereas non-striated are smooth muscles. We also have voluntary and involuntary, with skeletal being the only voluntary muscles of the body, and smooth and cardiac being involuntary. So now we have origin and insertion. Typically, the origin is the attachment of the muscle that doesn't move when the muscle contracts. So the insertion moves towards the origin. You'll also hear sometimes other terms that are a little clearer, like proximal versus distal attachment, or superior, inferior, medial, or lateral attachments. So normal skeleton system, remember the skeleton system normally consists of 206 bones, but it is not all that uncommon for people to have an extra or one less. So bones have a lot of main roles, right? But bone is essentially a key tissue for our entire bodily function, because of the fact that it's where we get the blood cells from, right? So that changes throughout life. Bone also undergoes constant remodeling. There is a law called Wolff's Law, and the more stress that a bone experiences, the more that it will build up. Bones can be classified in different ways, such as long bones, sesamoid bones, flat bones, etc. So types of joints, generically, right here, you have your ball and socket, which is the most freely movable. And then there is other joint types like your cranial sutures that theoretically don't move once they're fully formed. And then we have like chondroid type joints like your pubic symphysis. The entire purpose of joints is to allow two bones that are next to each other to be able to move. A rough way to characterize these joints is based on their type or based on their ability to move or what is within them. So a generic classification with our immovable joints, these are the synarthrodial types. They're connected by fibrous tissue. That's like the sutures of your skull. We have slightly movable joints. These are amphiarthrodial joints, which are connected by cartilage, like your pubic symphysis. And then there are our diarthrodial joints, which are synovial joints. These are our most freely movable joints, and there's various different types of synovial joints, ranging mobility-wise from your shoulder all the way down to a less mobile joint like the facet or zygapophyseal joint of the spine. So ligaments and tendons. Ligaments connect bone to bone. They help restrict essentially bones movements. Now, tendons, on the other hand, they attach muscle to bone. They don't have a high amount of elasticity in them because they still want to be able to contract. You do have a little bit more elasticity in ligaments. When there is a injury to a ligament, it is called a sprain, whereas if we have an injury to a tendon or muscle belly, we would call that a strain. Right here is an example of ligaments and tendons around the knee. Then there is fascia and cartilage. So throughout our entire body, we have connective tissue that is loosely organized that separates different layers of tissue. If you ever were to view a gross anatomy dissection where they are dissecting a human body, you would get a good idea of what this fascia is, because you spend a lot of time separating the fascia in order to separate out different layers of structures in the body. Now that we have cartilage, multiple different things make up cartilage. There's also different types of cartilage, but the idea is that it is a supportive tissue at the end of bones that help absorb impact and also function to reduce friction. And then one other final classification, something that doesn't exactly fit in to any other category, is bursa. These are like little sacs of fluid. Typically we see them under tendons or other structures in order to help those tissues glide without causing friction on other structures. Now, fibromyalgia, first condition we're going to talk about. This is a chronic pain condition. People typically have stiffness and tenderness around the body. It's going to affect muscles, joints, ligaments, etc. There's pain everywhere, right? In fact, the standard testing for this from the American Rheumatological Society involves 11 of 18 outlined so-called tender points of the body. We're going to see a diagram on the next slide that shows those tender points. But with fibromyalgia, we're also going to see a lot of psychological related conditions, because chronic pain does alter the nervous system. You get a concept called central sensitization, and you could also have peripheral sensitization. So the body reacts inappropriately to low levels of sensation, specifically anything that would signal pain. So in these people, in a normal person, you can apply 20, 30 pounds of pressure on someone and they'll start to feel pain. In a person like this, you barely are palpating the skin. Just resting the weight of your hand on them can cause them pain, right? With that central sensitization, you start seeing increased signaling in these pain pathways up the spinal cord into the brain. That pathway is called the spinothalamic tract, if you want to learn more about it. We also get changes within the brain itself, such as the thalamus having higher numbers of dendritic cells, which are essentially the primary immune cell of the central nervous system. But what happens is when there's more of them, they end up releasing inflammatory cytokines as a response to pain. And because of the location of a lot of the pain signaling in the body, there's a area called the periaqueductal gray matter that sits right next to the thalamus, and those inflammatory cytokines spill out into that periaqueductal gray matter, and that periaqueductal gray matter is actually one of the primary ways in which pain signaling is upregulated again. So you kind of see this positive feedback loop where we're feeding in a sensation, and that sensation is being amplified by signaling back down to where the sensation comes from, and the body continues this nasty process. There are realistically no specific studies or diagnostic tests for this other than the tender point examination. There is correlations with this condition for people that have various types of metabolic related diseases like hypothyroidism. You can also see issues with the parathyroid gland, certain types of muscle diseases, as well as viral infections or cancers. For a patient with fibromyalgia, though, the major thing that you want to look for is a full person approach to healthcare, the full biopsychosocial model, where we're not only addressing the biological symptoms, but the psychological and social impact of their condition on their life. So here are 18 tender points. To officially be diagnosed with fibromyalgia, the person has to essentially have what's called a jump sign upon palpation of each of at least 11 of these tender points. A jump sign is essentially when you're barely palpating on somebody, it causes them so much pain that they actually have a movement-based reaction to it. Next, lordosis. So One of the most common things related to neck or lumbar spine pain is a increase or decrease in the natural spinal lordosis. Both the cervical and lumbar spine have what's called a lordotic curve. Your sacrum and thoracic spine are naturally in a slightly kyphotic curve. Okay, so with increased lordosis, you have that increased inward curvature. That's going to end up leading to more stress on the joints and the vertebral bodies through the area and the discs, and it's actually going to result in less efficient load transfer down the body. Typically with the lumbar spine, when people are obese, they get an increase in lumbar lordosis because of the extra weight on the anterior part of the body. Individuals that are in like a car accident, they can end up having a decreased cervical lordosis from the muscle contractions that occur from whiplash. That can either go away or persist essentially forever, depending on the severity of the whiplash injury. As mentioned with obesity, you also get an increased lordosis with pregnancy. One of the major treatments that works really well for lordosis is attempting to activate musculature that we have been neglecting. So you're going to want to perform pelvic tilt-based exercises. Commonly, we talk about something called McGill Big 3 in the rehab setting. You can do the lateral bridge, the modified curled up, and the bird dog. All of those things help with posterior pelvic tilt. Our textbook does mention that a brace can be needed, but we have been going away from the use of braces because braces don't actually lead to a solution. They just create dependency of the body. So this is just showing your lordosis versus normal. So kyphosis, as mentioned before, our thoracic and sacrum have a naturally kyphotic curve. We don't see really a change in the sacral kyphotic curve because the sacral vertebrae are fused. But with increased kyphosis, you're going to get an abnormal outward curve. So you kind of get a hump in your thoracic spine. There are several conditions that can increase kyphosis, such as Scheuermann's disease, ankylosing spondylitis. They also talk about acute kyphosis with compression fractures or any other type of wedging type fracture in the thoracic spine. We can also see increased kyphosis with various other types of degeneration as well. Again, just like the other things with kyphosis, you want to strengthen musculature. So in this case, you're going to do things like the Brugger's position. You're activating your rhomboids, pulling the shoulder blades back, sitting the thoracic spine upright better. So this diagram shows us our kyphosis. Now, scoliosis. Scoliosis is the lateral curvature of the spine. It's more common in females, and it's also more common in adolescents and is typically idiopathic. There are other types of scoliosis, like you can have a scoliosis caused by various types of tumors. You can have something called a hemivertebra, which means only one side of a vertebra has developed. It's lateral wedge shaped typically, and that causes a acute focal deviation. You can also have naturally uneven leg lengths. So if a kid has what's called a Salter-Harris fracture that involves the epiphysis, which remember the epiphysis is the part of the bone that starts off as cartilage, it keeps growing, and then as it grows, it ossifies. That's your growth plate, right? So if you injure your growth plate, you can have a temporarily or permanently suspended growth pattern in that area. And that can lead to literal differences in limb length. And in this case, we're talking about essentially any of the bones in the lower extremity can help cause this. And you can get a rather significant scoliosis with just a small amount of limb inequality. There's also other conditions that have been linked to scoliosis. like something called a syringomyelia, which is it's kind of like a tumor, but it is a dilatation of the central canal of the spinal cord where the CSF flows right down the middle of the canal. It dilates out. Not exactly sure why that occurs, but there is a trend, especially when you see people that have a certain pattern of scoliosis. And then there's also Chiari malformations, which are also associated with syrinxes, but they can occur on their own. A scoliosis is associated with that. You can also get things like neurofibromatosis, where a tumor grows on the nerve sheath of the nerve root coming out of the spine. That can lead to changes of the spinal biomechanics and can cause acute scoliosis. But yeah, there's all sorts of different things. One of the most common forms of treatment, though, with mild scoliosis is just watchful waiting, because typically, once a child reaches a certain age, their spine is going to become skeletally mature, and their scoliosis should not continue to progress, especially if it's an idiopathic variety. Now, if there is a structural cause, then there might be, if the scoliosis is actually causing issues, they might do something to help alleviate it. But generally, you have to have a pretty severe scoliosis in order to receive surgery. Some pieces of the literature say as small as 35 degrees, but typically you're talking about orthopedic involvement at 40 degrees or above. For a functional scoliosis, that's pretty much anything that exists when the patient's standing upright, and I'll show this here. If the patient's standing upright, you see the scoliosis, but then they bend forward in what's called the Adams test, like they're showing here, and the curve actually restores. That's called a functional scoliosis. Not as worried about that at all, especially because that tends to be less than 15 to 20 degrees and typically is relatively asymptomatic. Now, if the patient bends over and it's still present, we're looking at a scoliosis that's somewhere at a minimum of 20, 25 degrees. And there has been a lot of success with bracing, particularly the Milwaukee style braces that the kid would have to wear for full time. But once someone is skeletally mature, the odds of correcting their scoliosis is exceptionally low. And the odds of their scoliosis progressing is also exceptionally low. Okay, so osteoarthritis. Osteoarthritis is the breakdown and degeneration of cartilage in joints. Now, the name of osteoarthritis is actually a misnomer. Osteoarthritis is not inflammatory like the itis would say. We don't actually have an underlying inflammatory nature to it. Now, you can get inflammatory reactions related to the degeneration, and inflammation can occur in advanced stages. But the idea, the simplest way to describe it is that you have an imbalance between the natural building and degrading of cartilage as part of the normal remodeling process. Remember, just like bone has osteoblasts, osteoclasts, OA sees an imbalance in cartilage turnover. You eventually start to have for more and more breakdown and less chondrocyte type activity where we're actually building up the cartilage. You might see osteoarthritis referred to as things like degenerative joint disease, degenerative arthritis in the spine. It's degenerative disc disease. It typically occurs in our weight-bearing joints. Hip and knee are the most common. Shoulder is actually relatively uncommon, and if it occurs in the shoulder, there's typically a overlying factor to it, like muscular injury or trauma. Now, osteoarthritis is actually something that we've started to gain a high understanding of in the last year. Now, I know on the last page here it mentions that the exact cause is unknown, but we've actually determined that osteoarthritis is a metabolic process. And individuals that have diabetes, individuals that have that are obese, they are more prone to osteoarthritis. Why is that? So it actually isn't fully understood, but it's related to signaling pathway of something called CAMP. Now, why do we know that increased blood glucose and insulin resistance help contribute to osteoarthritis? Well, we found that by analyzing cartilage, there's increased levels of inflammatory fatty acids that actually get deposited within the cartilage. And we also see that in individuals with diabetes who are given the drug metformin, which we will talk about in another lecture when we talk about drugs for the endocrine system, specifically for diabetes, metformin helps reduce blood sugar. We've actually seen in individuals both with and without diabetes that are given metformin, they actually have slower rates of cartilage degradation and lesser progression of their osteoarthritis. So there's a lot more to this condition than is currently known, but we are making major steps. And surgeries to fix it, like joint replacements, are getting better and better as the years go on. In fact, nowadays a hip replacement, which used to be potentially several days in the hospital afterwards, nowadays they're getting you on your walker and you're walking out of the surgical center after a few hours, right? So Lyme disease. Interesting thing about Lyme disease, no one's immune. Lyme disease is spread by ticks. It is Borrelia burgdorferi. The most typical characteristic physical exam finding, though, is our target-based lesion. This is called erythema migrans, meaning the outer portion that makes it look like a target is actually migrating outward. So it is possible to notice a giant red mark on somebody, but that would just be the early formation of the target lesion. Other common symptoms of Lyme disease, you're going to get fatigue, you're going to get muscle pain, you're going to get all these generic like symptoms, but it's important for you to know what areas of the country are common for Lyme disease, like the Northeast, like here in Buffalo. It's incredibly common. Generally is thought of to be underdiagnosed. People that have issues with fatigue, this is one of the things that needs to be looked at, and they diagnose it with a specialized Western blot to look at antibody titers for the many different forms of Lyme disease. Typically, though, the treatment, you remove the tick, you take antibiotics, and you rest. That's all it is, right? Not all tick types carry Lyme disease. So if you are bit by a tick and you are unsure how to identify different types of ticks, if you remove the tick from yourself, it's always a good idea to save it in a jar in case you need to identify it in the off chance that Lyme disease is a concern. Next, bursitis, as we talked about, inflammation of the bursa, which are tiny fluid sacs that reduce friction of the body. Basically, you're going to get increased inflammation. The bursa kind of stiffens up, and it leads to increased friction, which can, in certain parts of the body, lead to further issues with other anatomical structures. So what you're seeing here is one of the bursa, two of the bursa actually within our shoulder, two very common bursa to be injured, your subacromial and your subdeltoid bursa. Your subacromial bursa, if that gets inflamed, typically is going to reduce the space available for your supraspinatus tendon, which is this muscle right here. It compresses down on that, and it can help contribute to something called impingement syndrome, shoulder impingement syndrome, because this area would get reduced. Typically, though, bursitis is not a primary condition. It's typically related to something else. So in a lot of people, the supraspinatus actually is injured first, or something else is injured first. You can also have things like trauma, direct impact, especially that subdeltoid bursa, your trochanteric bursa in the hip. That's lateral to your greater trochanter, just anterior to the start of the IT band. That guy is prone to inflammation if you fall directly on your lateral hip. Most common treatment, though, rest, heat, and over-the-counter NSAID. If the swelling inflammation fails to go down, corticosteroid injections can be effective. One of the big things, though, is you want to reduce inflammation of the area, and you do want to ensure that the person keeps moving. Osteomyelitis. Now, this is a bone infection that needs highly aggressive antibiotic treatment. Once infection gets into the bone, that is a bad, bad sign because our blood cells are all made in the bone. Bone is highly vascular, and it's so hard for us to get to. So the most common involved bones are the proximal humerus and tibia, as well as the distal femur, and sometimes via the vertebrae. Certain types of bone infections love vertebrae, like tuberculosis. Tuberculosis loves the vertebrae. When it's in the spine there, you call it Pott's disease of the spine. So, primary symptoms are that of a general infection. Chills, fever, sweating, extreme fatigue. If you develop subperiosteal abscesses, you can get pathologic fracture as the bone will get eaten away. Typically, Staphylococcus aureus is the organism responsible for this, but in individuals that are immunocompromised, there can be other types of infection like Klebsiella. You see that at a higher rate. And in individuals that are IV drug users, you'll actually see completely different types of bacteria responsible for the infection. So this is what a anatomical specimen with osteomyelitis looks like. This is the abscess right here. You can also see that there's damage to the bone marrow up here because this is normal red bone marrow right there. Treatment, typically long-term antibiotics, increased intake of protein, and vitamins A, B, C, because all of those have a key role in helping the body fight infection as well as repair connective tissue, especially vitamin C. Vitamin C is a very important part of connective tissue. Person will rest, you'll immobilize the affected part, and in some cases, surgery will be needed, especially if there's extensive damage to the bone. They might end up, once the infection's gone, doing things like curettage, where they put cadaver bone fragments to help jumpstart the healing process. And in really extreme cases, they might have to do partial replacement of the bone. Like if it, in this case here, this is pretty extensive depending on how deep the infection goes. They might need to insert a rod in the middle of this bone to ensure that the bone maintains a high level of strength. They could also do things like put plates on the outside, but that's highly variable. Next, gout. Gout is another inflammatory arthropathy, except this is one of the crystalline arthropathies. What happens with gout is you're going to get deposition of uric acid crystals inside the joint. Those uric acid crystals rub down on cartilage, cause inflammation. It's not fun. Gout is related to individuals that eat high levels of purines in food. Purines are available in high quantities in things like wine, red wines, beer, red meat, and various other foods like that. The primary way to diagnose gout is a joint aspiration where you look for the urate crystals. But gout also has a rather stereotypical look. As you'll see here, this shows a hand and a proximal interphalangeal joint, but the most common joint affected by gout is actually the first metatarsal phalangeal joint. Treatment is going to involve rest of the affected joint. You'll use cold packs to help reduce inflammation, NSAIDs, and in higher, more extreme cases, corticosteroids. You'll want low purine diets. They'll also use a drug called allopurinol. which is a anti-hyperuricemic medication. And in a lot of people with this condition, they need gradual weight reduction. They need to lose weight. Next, Paget disease. So Paget disease is a bone softening condition. Typically involved in, it's typically older people. But what you get is new bone being made faster than the old bone can be broken down. And we'll explain that on the next slide, how that happens. But generally, the symptoms start as localized bone pain. It is possible for the person to have no symptoms and it just be a random finding. There are two stages. You have an initial vascular stage where the bone is broken down, but spaces are left that get filled with blood vessels and fibrous tissue instead of new bone. And the second stage is our sclerotic stage, where the vascular tissue actually hardens and becomes similar to bone, but is actually incredibly fragile because it's not bone. So this is an x-ray of Paget disease of the femur. The characteristic radiographic findings for this are this thickened cortices, but you also got these coarse-looking trabecular patterns. You also get your bowing deformity of the extremity because, again, the bone is soft. Next, Marfan syndrome. This is actually a group of diseases that are associated with connective tissue and but the major issue for these people are retinal detachments as well as aortic aneurysms. Because of the aortic aneurysms, this person typically will actually not live very long. Typically, somewhere between 25, 35 years old is the expected lifespan for someone with Marfan's. Interestingly, one of the most common ways to diagnose Marfan's is looking at the person's limb length. They tend to be much longer limbs than a normal person. These people tend to be taller. They have what's called arachnodactyly, which is really long fingers. And in someone with Marfan's, one of the stereotypical findings is that they can fold their thumb across their palm, and it will be longer than the width of their palm by a significant amount. It is related to chromosome 15 defect. One of the most common early symptoms of the condition is mitral valve prolapse, which is another common abnormality. So you see here a big list of different types of symptoms. The two main things, though, are aortic aneurysms and the aortic dissections, which is basically where the lumen is no longer patent. The inner layer of the aorta actually peels away from the wall, blood gets in between it, and it continues to peel it all the way through. It eventually will result in a lack of blood flow and death. Next, bone tumors. So these are going to be tumors that are primary bone tumors, meaning they originate in the bone. Typically, we look at tumors being based from cartilage, from bone tissue itself, or from fibrous type tissues. There are lots of different types of bone tumors. Benign bone tumors, again, just like any other type of benign tumor, can be a problem, but they can also not be a problem. Some of them resolve on their own. The biggest concern with bone tumors is the replacement of functioning bone tissue with non-functioning bone tissue, leading to weak bone and potential for fractures. There are many different types of bone tumors, but the five most common. Multiple myeloma is the most common type, typically in older individuals. Osteosarcoma, as you see on the screen right now, osteosarcoma is the most common bone tumor in young children, but it can happen in the adult population. It has a second peak at the older ages, especially in individuals that have had another type of cancer. Then there is our chondrosarcoma, which is the second most common bone tumor in an adult. And then we have our Ewing sarcoma, which is our second most common primary malignant bone tumor in a child. So treatment and prognosis depends on the tumor type, depends on the size, depends on the location, just like every other type of tumor. With bone tumors, though, especially malignant ones, they do not like to risk metastasis. Bone tumors love to metastasize to the lungs. They love to metastasize to the brain. They also sometimes metastasize to places like the kidneys and adrenal glands. But the important thing is that, especially in a young child who has them, the cancers like osteosarcoma and Ewing sarcoma can be very aggressive. So they will typically do amputation and take the limb. Muscle tumors, just like bone tumors, different types based on different structures. You're going to get pain and tenderness of the muscle. You're going to get increased pain local to the muscle. There is sometimes bleeding internally of the muscle. And the fun thing about muscle tumors is that they can actually kind of spread out through the space normally occupied by fascia and cause all sorts of other issues. They like to do surgical resections of these muscles, typically also still combined with your chemo radiation to ensure that they don't exist. Like with all tumors, the worse the tumor is graded, the worse the prognosis. Next, osteoporosis. So, osteoporosis is a condition related to deterioration of bone. It's conceptually similar to osteoarthritis, where we get an imbalance in the turnover of tissue. So in this case, we have an imbalance of osteoblasts and osteoclasts. Our osteoblasts slow down in activity with age, meaning we get less bone building. Osteoclasts continue to maintain a pretty steady rate, and you see degradation of the bone like you'll see on the next page. One of the most common areas to see osteoporosis is in the vertebrae, but you'll also be able to have a good estimate of it with the proximal femurs using a radiographic structure called Ward's triangle, where you see the different patterns of trabeculae of the femur. But the primary way to actually diagnose osteoporosis is not an X-ray. An X-ray just gives you an idea that there actually is a loss of bone density. A DEXA scan, which is a dual X-ray absorptiometry, you'll use that to get a better idea of the actual bone density. One of the major concerns with osteoporosis is increased risk for fracture. We typically see osteoporosis occurring in the older population, particularly postmenopausal women are most at risk. But individuals that also don't exercise and load their bones, they tend to also be at risk. Fractures of the vertebrae are relatively common with this. That's why you actually will see the whole stereotypical idea of the old grandma. She's, shrunk 3 to 4 inches over, 10, 15 years. It's likely because there's multiple minor compression fractures, particularly throughout the mid to lower thoracic region of the spine. On their own, these actually aren't a major concern. They're typically considered stable fractures, but if you do have what's essentially a progression to something called a burst fracture, where the body is actually exploded into pieces and moved, then that can be major issues, and you can actually get neurological symptoms. Osteoporosis is also related to certain types of nutritional malabsorption, like if you have deficiencies in vitamin D. Vitamin D is important for the metabolism of calcium. You can have something called a calcium wasting nephropathy. Immobility also causes osteoporosis. You can have regional osteoporosis from two primary things like immobilization. So if somebody has a fracture, everyone has seen a person with like an arm fracture. They get their cast off and their entire arm on the casted side is smaller. They've lost muscle, so they've experienced sarcopenia. They've also lost bone density. Again, Wolff's Law applies, and the same concept exists for muscle. If you're not using it, your body will not maintain it. Another condition that can also cause regional osteoporosis is something called complex regional pain syndrome. There's multiple different things that can cause that, but it's essentially a imbalance of the sympathetic nervous system causing an overactive pain signaling response. The regional osteoporosis for that can be related to potential immobility, like if the person had a surgery that ended up causing the CRPS or a fracture or anything like that. But it's also typically related to the CRPS itself. So this right here, showing on the top is a metacarpal bone, but down here we actually have a vertebrae with that almost fish shape to it. So how do we treat it? In postmenopausal individuals, you might use estrogen, but one of the most common ways to treat it is balanced diets and vitamin D combined with calcium supplementation. But other supplements are also things like magnesium and phosphate. Now, there also are drugs called like bisphosphonates. They can help with osteoporosis, but ironically, bisphosphonates increase the risk of something called atypical fractures. So when a bone fractures, it typically fractures at the area that experiences the most stress, while atypical fractures actually leave bone vulnerable to fractures in locations that don't receive a lot of stress. It's rather weird, rather unintuitive, but the idea is like with the femur, the medial portion of the femur handles the most load. That's because of the location of the femur and the shape of the femoral head, neck, and body, the angle and the way that it translates. Especially in women, you get even greater loading in that medial aspect because you have a higher what's so-called Q angle. In these atypical fractures, you'll actually have the fracture occurring on the lateral aspect of the femur. Not normal, very strange. Next, osteomalacia and rickets. These are essentially the same condition. They're both related to vitamin D deficiencies. Osteomalacia is the form of this in the adult, and rickets is the form of this in the child. You end up with softened bone. Okay. This is going to be diagnosed with a blood test, but generally the primary cause for this is related to vitamin D deficiencies, whether that is related to the inability to get enough sunlight or get it from other sources like supplements. This shows rickets here because it is a bone softening condition. You see the bowing deformities of the child's legs. Next, hallux valgus. So this is a valgus deformity of the first metatarsal phalangeal joint. It's commonly called a bunion. This is associated with conditions like gout. There are some treatments for this that involve a greater toe box, which is the space that your toes actually fit. You could put padding. There's also a type of brace that kind of helps pull the valgus deformity a little bit more straight. They make footwear specifically for this as well. So this right here shows the bunion. Next, hallux rigidus. This is a stiff big toe. That's the degeneration of cartilage at the first metatarsal phalangeal joint. You essentially start to get a arthrosis of the first joint, meaning a fusion of the first joint. Most common treatment is anti-inflammatories. Corticosteroids can be used, but you have to be careful with corticosteroids in conditions where there is cartilage damage like this, because corticosteroids in a joint is exceptionally exceptionally toxic to chondrocytes. Next, hammer toe. So this is a condition where the toe bends upward like a claw in abnormal flexion. The nerves supplying the muscle of the toe are subjected to a continued injury, and you get imbalance in the foot and development of the hammer toe that you'll see on the next page. Proper footwear will be important for hammer toe. It can be congenital, but it's also associated with individuals that always wear high heels and children that don't have proper fitting shoes, especially shoes that are too small. So you see here, this child has a obvious case of hammer toe on their right second phalange. The common treatment for this, if it needs surgery, is you will insert a pin, and that pin's going to keep it straight, and they'll go for essentially fusion of the proximal interphalangeal joint, and sometimes the pin can be removed at a later date. Next, fractures. So fractures can happen anywhere on the body. Common types are what we're going to go through here. There's all kinds of different ways to describe them. Like there's a Colles fracture. Colles fracture is a named fracture. So it's a fracture of the distal radius with posterior angulation of the radius. You can also have what's called a Smith's fracture, which is a fracture of the distal radius, but it has anterior angulation. There's also other types of fractures that involve both the distal radius and ulna, all kinds of things. I've mentioned the Salter-Harris fractures before, which are fractures that occur in children and affect the epiphyseal plates, the growth plates. Humeral fractures typically involve extreme shortening of musculature in the extremity. You can also have minor types of fractures associated with dislocation, direct trauma. The pelvis is normally incredibly severe trauma unless the person is highly osteoporotic or has a pathology that leads to increased risk. Typically things like motor vehicle accidents or high falls. Same thing with hip fractures. Hip fractures are essentially fractures of the proximal femur, and you could even consider acetabular fractures kind of within that category. These are typically falls in elderly individuals or high force accidents. Femoral shaft fractures, these are more common in young adults and are normally direct impacts or motor vehicle accidents. Tibial fractures, these are associated with lots of soft tissue damage and nerve damage, particularly to your tibial and common fibular nerves. You could also have vertebral fractures of the neck. There's many different types. There's your hangman fracture. You have a Jefferson fracture, which is the fracture people suffer when they have an axial load onto their head. So the person who dives headfirst into the shallow end of the pool hits their head directly on there. They end up with that Jefferson fracture. That is actually a burst fracture of C1. Again, a named fracture. You have your flexion teardrop fractures, extension teardrop fractures. There's something called clay shoveler's fracture, which is just a spinous process fracture. You have your compression fractures, like we talked about before, in the lower lumbar, the lumbar and thoracolumbar region. You can actually have something called a lap belt or named form chance fracture, which involves splitting of the posterior elements. It's caused by flexion over a fulcrum, as in you get into a car accident that's pretty severe. Your body gets flexed over your seatbelt, your lap belt, and it causes a high force to essentially pull your vertebrae in half on just the posterior side. We can also see fractures named based on people, based on locations. Fractures are typically graded. Basilar skull fractures are at the floor of the cranial vault. Massive trauma to the head, motor vehicle accident are the most common things. You can see them in sports as well. Basilar skull fractures are associated with something called a battle sign, which is like swelling along the mastoid process, which is just behind the ear. And the person can also have bleeding out of their ear. There's Lefort fractures, which are a bilateral horizontal fracture of the maxilla. One of the most common ways that this happens is in a motor vehicle accident. The person's face hits the steering wheel. You can have a pot fracture, which is a named fracture for the distal fibula being fractured. Typically, if the distal fibula fractures, there is injury to the syndesmosis between the tibia and fibula, and you typically need to check the proximal tibia as well. Clavicular fractures, again, they can happen in different ways. You could have, translation of bones, things like that. So types of fractures. So you have the idea of simple versus open. In an open or compound fracture, the bone will actually be exposed to the environment. It may not be showing outside of the body, but if there is a break in the skin, it is considered an open fracture. Longitudinal versus transverse fractures. Different bones tend to have different patterns and different mechanisms of injury have different patterns as well. A longitudinal fracture in the femur, it would be a rather strange one. You typically get more of a transverse or oblique orientation, which you see here with letter E, that's our oblique. With F, you have what's called a green stick fracture. This is an incomplete transverse fracture of a bone. The big thing with a green stick is that you only see them in skeletally immature people. So this would be a child or someone you could consider like a young adult whose femur is not fully ossified yet. Next, we have G is our comminuted or multiple bone fragment fracture. And then we have impaction fractures, which if you look here, you'll see the femoral neck has kind of compressed on itself. Again, this is essentially a compression fracture of the femoral neck. Here we have pathologic fracture. This is showing some sort of pathology like a tumor that has weakened the bone. And then we have a non-displaced fracture. Non-displaced fractures can actually be pretty difficult to see on x-ray, as x-ray requires essentially about a 35% change in bone density. There are certain bones that are prone to having non-displaced fractures that are not necessarily viewable on an x-ray. The scaphoid, ribs, scaphoid and ribs, very common for that. Other bones, though, it's typically pretty obvious when there is disruption or of the cortex. Here we have a displaced fracture. So we have the idea that the fracture fragment has actually angulated laterally. So you will always refer to fractures based on their distal portion. So we see lateral angulation of the distal femur in K. You also have something called apposition, which is the idea of whether they're overlapping very well. This would be called, fair apposition. It helps orthopedic surgeons classify the injury and is important for pre-surgical planning. Then we have here our oblique spiral fracture. This is a more common type in the long bones, especially in healthy individuals. It has that spiral type orientation to it. We also have compression fractures that we've talked about already on M. With N, we have something called the avulsion fracture. This is showing something called gamekeeper's thumb, where the part of the proximal phalange of the first digit is actually been avulsed off by the adductor pollicis transverse head of adductor pollicis. And then over here we have the depression fracture, which we talked about as a potential cause for increasing intracranial pressure. We talked about that in the neurological conditions chapter. Typically, the major issues with fractures are associated with the healing time and if there is any underlying disease of the bone. Treatment's really going to depend on the individual, the type of fracture, severity, and what actually caused it. Simple fractures are going to be handled a lot easier than compound fractures. A big concern with compound fractures is osteomyelitis, because once the bone is exposed to the outside environment, it is very difficult to ensure that it remains quote unquote clean, because it's one thing for bacteria to try to get in through the cortex. It's a complete other thing for the cortex to be ruptured and the bone marrow, which is highly vascular, to be available to direct access from the outside. Very, very potential for dangerous. Amputations associated with severe traumas, malignancies, and congenital defects. But we can also see them caused by vascular injuries, things like burns, or even extreme dislocations of joints. Rehabilitation is important. There's something called phantom limb pain, which is essentially the body is still using signaling pathways to the brain to signal that there's pain, but in reality, those the area of the body is no longer there. But the proximal portion of those signaling pathways still exist. So the body is kind of in a very confused state. People will often feel like they have their arm or their hand, foot, whatever, and with this condition they experience pain in it. One of the cool things about rehab of this, though, is they use visual tricks to kind of trick the brain that everything is fine. If you're more interested in it, you can look up videos on YouTube about mirror training for phantom limb syndrome. Strains and sprains, already talked about this before. Typically, they're associated with sports, but they can also be any other type of acute trauma or chronic overuse. They're going to cause localized pain. Typically, with grade 2 and higher strains and sprains, you'll get weakness. You can also experience numbness and edema of the area. Again, these things are graded scale 1 through 3. Generally, the idea is scale 1. Minor edema, the main symptoms mostly pain. You typically don't have extreme weakness. Once you hit grade 2, you start to see real disruption of the muscle or ligament, regardless of whether it's a strain or sprain. You start to see some weakness, and you might get a little bit of edema. Once you start to hit a stage 3 injury, you're running into a majority of the structure being actually, disrupted. It's going to be torn. So if it's muscle, you're likely to see bruising. You can even see, like in the bicep, what's called a Popeye sign, where part of the muscle has retracted because the tendon is no longer attached. With sprains, when you do things like an ACL drawer test, you won't feel the end point. There's likely in a strain to be a ton of edema. But again, these injuries can progress, especially when you talk about strains of muscle. You can start off with a grade 1, but if you don't let it rehab properly, you'll eventually progress to a grade 2 and even a grade 3. Treatment. The old accepted method of treatment is RICE. Rest, ice, compression, elevation. Now, we have found it's actually a little more nuanced than that. You'll see many different new acronyms for it, like peace and love. But my favorite to use is just real generic. It is the acronym METH. So it's movement, elevation, therapy, and heat, right? So this is showing your ankle sprain. So with a typical ankle sprain, the most common ligament to be injured is that anterior talofibular ligament. A little bit more of a severe would also involve your calcaneofibular ligament. And there's a third ligament on this side that's not demonstrated, but it's your posterior talofibular ligament. To get all three of those guys would require a pretty significant lateral ankle sprain. Your medial ankle typically does not get sprained because you have a very, very robust ligament there called the deltoid ligament. That's actually the combination of 4 different ligaments that have fibers that all run within each other. So dislocations are forcible displacements of bones from joints. You lose joint function in this case. Dislocations can be partial, which is referred to as a subluxation, or full, which is a luxation. These can be dangerous. Certain dislocations are much worse than others. Like if you have a true knee dislocation, so the actual tibiofemoral joint, not the patellofemoral joint, your tibiofemoral joint has dislocated. You have extensive soft tissue injury, including ligaments, but you're also at risk of damage to the sciatic nerve, branches of the sciatic nerve, and the life-threatening component is potential damage to your popliteal artery. If that is severed in a true knee dislocation, the person can bleed to death rather quickly. So dislocation of the shoulder, we typically see the shoulder dislocating anteriorly, which is what our diagram here shows. It comes anterior and inferior. That's your fall. That's your posterior impact. That's your typical injury. Now, a very, and this is over 90% of shoulder dislocations occur this way. It is possible to have a posterior shoulder dislocation, but that's associated with things like electric shock and seizures. You can also get a rather interesting type of shoulder dislocation where the arm is in an abducted position and you get a force on it from above, and it actually causes the dislocation to where your arm is stuck up over your head. You actually cannot move it down. A major risk with the relocation of dislocations is actually fracture of the bone when you put it back in. So sometimes you will see people getting x-rays both before and after because a dislocation can cause a fracture. Like with the humerus we see here, it's very common to see two injuries with this. You can get a Hill-Sachs lesion, which would be essentially a chip fracture from the humerus. As it dislocates, it comes back and hits the glenoid rim. And when it hits the glenoid rim, it will cause a bit of an impaction injury. And you can also get what's called the Bankart lesion, which is damage to the labrum, essentially, around the glenoid rim. Both of those things can happen, and they're relatively common with these dislocations. So adhesive capsulitis or frozen shoulder, this is essentially a condition marked by a clinical finding of pain without a lot of movement in the shoulder. It's not all that uncommon, especially in older people. It's related to other underlying conditions, though. This is not, just like bursitis, this is not something that happens on its own. You might find things like damaged musculature. You might have a inflammatory arthropathy. You could get stuff like calcinosis occurring within tendon. And there's also other things that cause it, like SERVA, which is where an individual, rather than a vaccine being given in the deltoid, it's given too proximal on the arm, and it actually ends up with the vaccine contents being injected into the joint. That can also cause frozen shoulder. But generally, our book is a little outdated again in this case because it talks about scarring of the joint. This actually isn't really true. A lot of our research actually tells us that there isn't really scarring and there isn't really any adhesions available. Okay. The key thing to this though is motion. Treat it with motion. Okay. Even if it is passive motion. You might also see in some cases, in extreme cases, for individuals that are licensed to do joint manipulation under anesthesia, you might see somebody with frozen shoulder undergoing anesthesia, and people with that specialty in education and experience in treating, they'll actually do joint manipulations to try to restore motion of the joint for these people. Severed tendons. So again, when we talk about this is like a grade 3 injury to the tendon. What you're going to get is muscular retraction. All right. You get, this is a complete injury. A lot of times you see severed tendons in the hand or the feet related to sharp object injuries, like stepping on something sharp, knives where you're, cooking in the kitchen and you sever through, a flexor or extensor tendon of the hand. Typically with this, provided they can grab both ends, they will actually suture them back together, immobilize the region to allow them to heal, and then slowly start working to restore motion. Shin splints. This is a very common condition where there's lower inflammation of the periosteum, which is the most outer covering of the bone, because of the extensor muscles in the low leg. It ends up leading to stress on the periosteum. Periosteum is actually very innervated with pain receptors, commonly caused by overuse and overpronation. Overuse injury for this is typically somebody who is a runner who has suddenly upped their miles a lot, or somebody doing high impact exercises and they don't normally do high impact exercises. A big thing for this is proper footwear, so making sure that you're not using shoes that are too old and worn out, and making sure that your exercise is actually appropriate for your training history, essentially. So making sure you're gradually ramping up. Treatment, though, really is a basic return to sport kind of thing after a short period of rest. A big thing to note, though, with shin splints is in rare situations, especially the overuse side, you can actually end up with stress fractures. So this is showing our excessive foot pronation. You're getting that dropping of the calcaneal angle. Let me draw on here. So normally this should be like this, but what we're actually seeing is a change in our calcaneus of, we're looking at maybe 15 degrees. This is a very severe case right here, right? Ideally, we want our calcaneus to run perfectly in line with our Achilles tendon, which is the part coming up here. This puts a lot of stress on that medial ankle, and it actually leads to knee changes at the knee and hip biomechanically, and that translates to potential for changes in biomechanics of the pelvis and low back. So people with foot pronation actually commonly have low back pain. Next is plantar fasciitis. This is commonly grouped in with other things like heel spurs, even though they are different things. But the plantar fascia is a big piece of broad connective tissue on the bottom of the foot, and it becomes taut and inflamed, and it makes it very difficult to put weight on the foot, especially when you are on the toe-off stage of walking or running. There is a risk factor list right here, but again, this is typically a clinical diagnosis. The initial treatment, though, rest and ice are very good, so are anti-inflammatory medications. One of the newer treatment modalities that have been experimented for this is something called shockwave therapy. Shockwave therapy has been shown to be highly effective for this, extracorporeal shockwave therapy. It's rather interesting, and if you're curious about it, I'd look up a video on YouTube. So here, this is showing a heel spur, which is, again, a little bit different, but this is different than an osteophyte because this isn't degeneration. This is actually called a syndesmophyte. So a syndesmosis is a syndesmophyte is where a muscle tendon attaches to the bone, and you get excess growth of the part of the bone. Next, we have ganglions. These most commonly develop on extensor surfaces of the body. The wrist is very common, and so are your neuromas, which are basically ganglions between your interphalangeal spaces, or sorry, your metacarpal, metatarsal interspaces. Commonly, they'll try to drain these, but it's very common for the swelling to come back. So they might do a surgery to actually remove it. So this shows a ganglion. A torn meniscus, very straightforward. We have 2 menisci in our knee. There's also menisci in the jaw. You've also got meniscus in various places throughout the body as well. Commonly, the medial meniscus is the one that's most injured because the medial joint space of the knee is the most weight-bearing. Most common symptom you're going to have is pain and a feeling of locking of the knee. Torn menisci do tend to be related to sports and physical activity, though. Not all meniscal tears are treated with surgery. It depends on the type. A more severe tear, like a bucket handle tear, where the meniscus would actually fold over and you'd end up with a big lump of meniscus there and nothing out here. That's prone to causing locking of the knee, and that can lead to other injuries. Rotator cuff tears. So there's 4 tendons that make up the rotator cuff. You have your supraspinatus, which is here, and it will attach here. You've got your infraspinatus, which is under the spine of the scapula that we can see here. So that would run here, attach here. And then you have your teres minor that runs along that bottom border and attaches to the greater tuberosity there. And then you have your subscap, which sits on the subscapular fossa, and that comes to the lesser trochanter there. So any of these can get injured, but the most common guy to be injured is this one here, your supraspinatus, typically related to overuse injuries, but it's incredibly common to happen in elderly individuals. In fact, I think it's statistically almost 60% of people over the age of 65 have a rotator cuff injury. Also super common in individuals that have metabolic diseases, specifically diabetes is very prone for any type of tendon issue, not just rotator cuffs, but you get a lot of bicep tendinopathies. You get patellofemoral pain syndrome, which is related to pain of your quadricep and patella tendons. And you just get overall weaker connective tissue in those diseases. A big thing you would find on an x-ray, though, now, again, remember, you don't normally see soft tissues on x-rays, but you can actually get an idea of if you would need an MRI for somebody with a supraspinatus injury, as an example, because the humeral head would actually translate up slightly, and you would get a decreased acromial humeral space, which is another sign of impingement, like we talked about earlier. So that is everything for our chapter on musculoskeletal diseases and conditions. If you have any questions, please make sure to ask.